Let's move on to relapsed and myeloma. Unfortunately, this remains a chronic relapsing disease, and we have to face the reality that many of our patients will relapse despite triple therapy and transplant and prolonged maintenance. How is the availability of daratumumab changing your approach? Cristina, how are you using that drug?
Yes, I think it's my first drug, combination of course, in first relapse. We do have the data from the Castor, the Pollux, that they look great with a huge number of patients achieving a very deep response in relapse, in the first relapse, which is amazing. We have never seen it before.
So just for the audience, Castor was bortezomib,
daratumumab, dex, and the Pollux.
Against
bortezomib and dexamethasone.
And what was the Pollux trial? So the
daratumumab with the lenalidomide dexamethasone compared to the lenalidomide dexamethasone.
Right.
And so we do have strong data, also updated here at this ASH meeting, again showing 26% of patients achieving MRD in first relapse. And if that will translate with the longer duration of response, it looks like. So, and daratumumab is definitely improving the depth of response.
So are you using it, so maybe let me turn this one to Bob. A lot of us have been using carfilzomib at first relapse. Are you using daratumumab or carfilzomib, or how do you decide which?
Yeah. Well, because many of these folks who relapse after frontline therapy are on some kind of len-containing maintenance, what we've been very frequently doing is pomalidomide with daratumumab, especially if people have really rapidly progressive disease. I think if you have a small biochemical progression, you could even argue maybe not to do dara and just add a little bit of steroid or up the dose of the lenalidomide a little bit. But if you have clinical progression or rapid biochemical progression, I like to make two new drugs in. And so I do use dara with POM, and you can use dara with carfilzomib as well, although it's not FDA approved. So that's a good combination. And then finally, carfilzomib with pomalidomide and dex is another good regimen.
So forced to make a decision, is it very patient specific, or do you have your favorite?
I would say my favorite is probably dara with POM and dex, in part because since it has FDA approval, it's a little bit easier to get approved from an insurance perspective, but I'm equally comfortable with carfilzomib, POM, and dex.
Okay, let's hear from the others. Noopur?
I use either or, and I do think it's really patient dependent also. And when you're talking about relapse, there's so many factors which come into play. And I think it's important to try and appreciate how long a patient has been on len maintenance. Somebody who's been on len maintenance for 4 years, I'm not going to jump to a dara-based regimen right away. Somebody who's relapsing within 2 years of a transplant has a much more aggressive relapse. And those are the kind of factors which help you decide one over the other.
Is everybody using pomalidomide in a patient who's been on lenalidomide maintenance, or is anybody increasing the lenalidomide dose?
There's a lot of nuance to treating relapse, as you very well know. So for me, the only study that now has shown a triplet being showing survival advantage is your study, Keith, of the ASPIRE data that is now being presented at the meeting with overall survival advantage now for the
And for the audience, the ASPIRE trial is?
The ASPIRE trial was this large randomized study headed by our host, Dr. Stewart, comparing lenalidomide dexamethasone versus carfilzomib lenalidomide dexamethasone for early relapse of myeloma. And now this study has an overall survival advantage for the triplet with carfilzomib lenalidomide dexamethasone. So for me, carfilzomib-based regimen versus daratumumab regimen is the backbone, as we just discussed. For patients who've been on a very low dose of lenalidomide and are just progressing, I usually go up on the lenalidomide and add carfilzomib in. But for patients who have a rapid progression and they have prior proteasome inhibitor exposure, I'm with Bob and try to go with daratumumab there.
In patients who are a bit older, carfilzomib could be a little bit more challenging. What is your regimen of choice, Bob, in a sort of elderly patient who's relapsing? Would it still be daratumumab-based?
I think dara, POM, dex is a good agent or combination for those folks, and with hopefully soon the ability to give dara subcutaneously, which seems to be even better tolerated. That would be a good regimen. And then ICSA with POM and DEX, although another one of those not yet FDA-approved combinations, but that can be very effective as well.
We'll come back to elotuzumab and ixazomib in a minute, but since we're on pomalidomide, there was one abstract that caught my attention in which the incidence of deep venous thrombosis in a very large study from the United Kingdom was quite high, about 10%, and compliance of the treating physician with recommended guidelines wasn't very good. So, Cristina, what do you tell your patients about blood clots and using immune modulating drugs?
Yes, you know, in that abstract you're referring to, the incidence was quite high particularly during induction therapy. And what they noticed the incidence was higher on patients that they're deemed to be at high risk, but despite that, they were only on aspirin. So I think we have to be cautious about these and maybe be more aggressive, particularly in the induction for patients with high risk of...
So aspirin for most, but for the high risk?
Yeah, right. We may need to, you know, select these patients. I think that was the message, that we have to go back to a more aggressive, more sustainable anticoagulation mode.
Fully anticoagulate them.
I think a point for that study, though, is also it was chemotherapy with IMiD, Cytoxan-based treatment, and that's maybe why the risk was a little bit higher there. Right. So we don't necessarily see the same risk in a PI IMiD-based combination.
I'm glad you mentioned Cytoxan. We often forget to talk about that in these sessions. It's still a very useful drug in combination in many of these patients.